one of the fathers of functional medicine used to talk about tacks on a chair and sitting on all the tacks. When you do the elimination diet, you remove a lot of the tacks because there's a lot of things that are constantly interacting. A lot of people are ingrained in food habits. A lot of people for breakfast are having a bowl of cereal. For lunch, they're having 2 pieces of bread and some lunch meat and some cheese and maybe some chips. And so far, I haven't seen anything green or fruit related in their diet. And they might have some carrot sticks and they might have a piece of fruit that day. But most people are failing at the take 5. And I know that you're aware of this, but when you sit down and you drill down and you start to ask someone about their diet, most people are very hurried, they're very rushed, and they're not even coming close to what they should be eating. To eat right, you have to be very intentional, and it's very similar to swimming upstream. Has anybody in this room ever tried to swim upstream? I think it's really hard. I think it's almost impossible. And if you think about the cultural messages that are sent to us all the time about the food that we should be eating and the food that's great. So when to use this? Chief complaint, bloating, indigestion, joint pain, muscle aches, immune dysregulation, fatigue. I had a patient who's a nurse come see me a couple of years ago, and she has a hereditary disorder where her dad was in a wheelchair at 40, and it's where her mitochondria don't work and her muscles are really stiff. And I remember thinking to myself, I had this little battle going on in my head. I thought, she could barely walk in. Here she is, this nurse. And I thought, she's busy, she's got these boys, she's sick, she's got this hereditary thing. I'm going to ask her to do the elimination diet. I thought, oh my gosh, she's so busy. How are you going to do this? She just put her on some supplements and do some testing. But then I said to myself, no, everybody does the elimination diet and her diet's horrible. She eats hot dogs. Do it. So I gave her the elimination diet and we discussed it and she left. And she came back 3 weeks later and she was 45% better and the vascular surgeon that she works with noticed. It's like you're not as stiff as you used to be. So, we were calming down inflammation in the GI tract and that was affecting those cytokines that Dr. Roundtree talked about, which ultimately were affecting her mitochondria. So it's a systemic model of medicine where everything is hooked together. And that's where medicine is going. So these conditions for GI are slam dunk, autoimmune diseases, asthma, so inflammation, atopy, skin inflammation, myalgias. I never promise anything to my patients. I just simply present it and I ask them to do it, and I also paint the grim picture. Because I think it's really important. So what is the elimination diet? So it's the elimination of food or food additives that could be causing the immunological or non-immunological reaction. And there's several different types. There's a simplified type, which is what's in the literature. It's lamb, pears, sweet potatoes, and rice. Caution, this is severely deficient in many nutrients. It should not be done for a long period of time. Or you can do food specific, so you can just get rid of gluten or dairy or eggs. You can do a FODMAP diet, a paleo diet, a low histamine. Or you can do the 6-food elimination diet, which is gaining popularity in the literature, which we'll talk about, or the comprehensive diet. It's all about, this is the point where the art of medicine takes place. And you look at your patient, you ask yourself what they're capable of, and you negotiate. I had a 14-year-old come see me whose mother is an ENT doctor. And she just had a lot of GI stuff, a lot of fatigue. And her parents were separated, and her dad was not supportive. Mom was supportive. And so we had this split household. And as I talked to her, we were able to negotiate wheat and dairy. And I knew, given that half of her life she was in many environments where she didn't get to pick her food, that was as good as we could get. And she did well with that, but there was a negotiation process that occurred. It's interesting, the American Neurological Guidelines talk about the elimination diet for interstitial cystitis, which is a horrible condition. It's incredibly painful, where the transitional epithelium inside your bladder is inflamed. I have a friend who actually was going to get an implantable pain stimulator for this because she was in so much pain. And we hadn't talked for about a year, and when I saw her, she was doing fabulous. She put herself on a raw diet, which means she cut out all the grains and all the dairy, and her pain went away. Isn't that amazing? And she didn't need the implantable thing. And who knows? She never did testing. I don't know if it was lectins, which can also bind to the transitional cell epithelium. I'm not sure what it was that was in her diet, but she's so much better now. She does have to do pretty strict adherence, or she has quite a bit of pain. So features of the elimination diet: it reduces inflammation, supports a healthy microbiome, which you're going to be hearing about more and more as the years come, dairy-free, gluten-free, phytonutrients, so it adds back in the healthy foods that are really good for you. And it's really good to have that recipe book and the menu ideas. Very important when you give someone an elimination diet that you give them ideas of what to eat, because people don't know. And that's why I like to have a health coach or a dietitian walk the patient through it. Identifies food triggers, promotes body awareness to food. There's absolutely no caloric restriction on the elimination diet. And I tell my patients, this is not a weight loss diet. You'll probably lose weight, but that's not the goal. I want you to eat all the time. Just eat the foods that are on the list. And they kind of look at me, because so many people are used to these really restrictive diet patterns. But the goal, again, isn't weight loss. The goal is there's a departure from foods that are in the sad American diet and adding back in the good things. So, what do you need? The first thing is an educated and committed patient. So, it's important when I do primary care, I give tools to help the patient get educated, webinars, podcasts. In my dedicated functional medicine clinic, by the time they've gotten to me, they've really already educated themselves. I do frame it with stories. I talk about research. I find that stories can be encouraging to people. And then I always give them the tools, so when they leave, they have the tools and usually a medical food. The medical food helps fill in the gaps for protein, as well as omega-3 fatty acids for inflammation, as well as B vitamins or other things that might be deficient. Now, patients that are not suitable would be pregnancy, someone who's had a severe reaction, and then someone who is very phobic about allergies, or someone who's anorexic. Now, I got blindsided by this a couple years ago. I had someone who was really intelligent in my office and very knowledgeable about food allergies. And I didn't catch it for about 6 months. And there was a moment when I thought, oh my goodness, this is an eating disorder and we need a psychiatrist. But I didn't catch it right at first. So you've got to be careful that when you're asking someone to eliminate food, you've got the right population. You don't want to be feeding something that's actually a phobia. So FODMAPs are fermentable oligo, di, monosaccharides, and polyols. And what they are is poorly absorbed short-chain carbohydrates. Fructose consumption in the U.S. is up 1,000%. 1,000%. It's in many of our foods. It doesn't have to be labeled. And what happens is there's been studies where they give humans 50 grams and they can actually measure through breath testing if it gets absorbed or not. And you can have different amounts of the GLUT5 receptor based on your genetics, which is how it gets in. If it's left in your gut, it can be fermented, and the visceral distension can cause pain through the afferent pathway to your brain, and that's called a functional GI disorder. Has anybody ever experienced abdominal pain from fructose? Okay, I have. Yeah, there's a couple of brave hands back there. When I was in the ICU in residency, I was overworked, and I went downstairs to the VA gift shop, and the only thing I could find that looked good was gummy worms. Yeah. That's really awful, isn't it? And I remember I was getting onto the elevator with all the dietitians. I just waved them. I thought, this is just embarrassing. But I ate them because I was trying to stay awake. And about 6 hours later, I thought I was having an appendicitis attack. I mean, pain right in here. I was like, oh my goodness, it was 10 out of 10. My stomach was blown up. I thought, I was bent over, just completely a mess. I called the chief resident. I said, I think I'm going to have to go to the ER. I think I'm going to have an appendicitis attack. And then, common sense took over, and I thought, wait a minute. You ate those gummy worms. Could it be fructose? Could you be having visceral hypersensitivity? So I just went to bed. And about 5 hours later, it all went away, and it's never come back again. But I've never eaten a bag of gummy worms again either. But could it be that when you're talking to someone with IBS, that actually they just have too much of these things in their diet and they need to do a FODMAP diet? That's in your toolkit. There's 3 independent mechanisms, which we've discussed: wheat, rye, onions, garlic, artichokes, legumes, milk, honey, apples, pears, watermelon, mango, stone fruit, sugar-free mints, mushroom, and cauliflower. The 6-food elimination diet, you're beginning to see more and more in the literature. These are the top 6 foods for allergies. And this is talking about eosinophilic gastroenteritis. I had the privilege of working closely with a colleague in Oklahoma who just retired, and he said to me, he said, you know, Betty, the eosinophilia research guys are esophagus guys, and nobody's looking down here. And what he would do is he would biopsy duodenums in many patients. He taught OU pathologists how to read the slides and how to stain them, and they were greater than the number that it takes per high-powered field to actually get the diagnosis. So he was fascinating in that he was using oral sodium dichromoglycate to calm down mast cells. And a lot of my patients who were unable to get traction would go see him, get the diagnosis, and for the first time, they've been sliding down a slippery slope. They were able to get traction and start climbing the hill. And again, it started with the GI tract. So this looked at 71% of patients that had reduced eosinophil counts, and they found a single offending food in 35% of the patients. Cow's milk was the number 1, wheat number 2, eggs and legumes was number 4. Now, prior allergy testing showed that there was no concordance. This is the histopathological slides before and after. And the conclusion was that empiric elimination diets involving the exclusion of 6 food groups most likely to cause food allergies are a suitable drug-free dietary treatment alternative for both patients with pediatric and adult EOE. Now, the signs of eosinophilic esophagitis are usually dysphagia and food impaction. And part of my history when I talk to a patient is I really do like to go through the GI tract. You know, do you ever have a sense of tingling when you have food in your mouth, when you swallow? Do you have any trouble? Do you ever feel like food is impacting here or stuck? Tell me about your stomach, and then we go through the whole GI process. And I'm sure that you're doing this. This is super basic, but how many bowel movements are you having a week or a day? And it's interesting, time and time again, my sickest patients are having maybe a bowel movement every 3 or 4 days. And a lot of the current dogma that's taught is it's okay to have a bowel movement every 48 hours, but with our toxic load, I'm not so sure I agree with that. So this is a key, 6-food elimination diet is a key thing to remember. In Nature of April 2019, they looked at epilepsy and food sensitivity, and they instituted the 6-food elimination diet, and they had remission of seizures that was significant. So it was a P of less than 0.001. So it's just fascinating to think about that. And they talk about in Nature of April 2019, they talk about this gut barrier and probably the compromised brain barrier that's happening at the same time. So some of the concepts, again, that we're presenting here are really emerging in the literature, and they make sense that everything goes together. So this demonstrated for the first time that continued avoidance of the offending foods with quiescent eosinophilic esophagitis could lead to maintained disease remission. So how do you do this? Single food, gluten-free, casein-free, modified, 6-food, FODMAP, or oligoantigenic. So what I'd like you to do now, we're going to take 5 minutes. I want you to talk to somebody at your table and discuss when you would encourage a patient to go on the elimination diet and what situations would influence which one you're going to choose. So it's super important to think about different scenarios to really broker, negotiate, think about your patient, really think about what you're doing, what you're going to ask your patient to be doing. I really like the IFM Comprehensive Elimination Diet. I use it all the time. And what's very important, and I've had feedback from patients, is it's very important, in addition to telling them what they can't have, be sure you tell them what they can have. So I like this because it talks about foods to eat and what you can have and what you need to avoid. And I usually give them this packet, and I have them work with a healthcare professional. I might have a dietitian that they work with. It's very important that they have someone hold their hand, and the literature also supports that. So I tell my patients, if they're super busy, to get some organic chicken, cook up a vat of rice, to never be hungry, have some different fruits and vegetables on hand, and always carry food with them. You want to make sure that you look at this in our toolkit. I actually have 50 copies of this run off in my clinic at all time that I use. And I have had my recipe books bound with that little black thing, and I give those to patients. So if you want milk, you could do milk substitutes like unsweetened rice, oat, or hemp milk. And it goes through the list of breads and crackers and what you can have. I kind of ask them to stay away from anything that's more than 5 ingredients or more. I'm really wanting to get away from all of the processed foods and the preservatives. So getting started, I ask them to read the whole thing. Make sure you read this. Make sure you give yourself about 2 weeks. Helpful hints of how to get started. Again, don't go hungry. Make sure you're choosing organic as much as you can, looking for cold-pressed oils, eliminating caffeine. And normally, the caffeine discussion, people need to get off caffeine about 2 weeks very slowly before they start. What seems really basic to me, a lot of people don't know. They just go cold turkey and then they feel horrible. So really cutting down on your coffee slowly. The role of anti-inflammatory foods and how important they are and what they do for your body, increasing those in your diet, making more of those choices, such as fatty fish, grass-fed meat, nuts and seeds, the omega-3 fatty acids. And then during the elimination diet, kind of what's happening to your body in that process, where it's taking about 8 to 10 days to where you really start to feel better. Normally my patients, a lot of them feel more tired, like they have the flu. Some have a nausea type feeling for the first couple of days. It's actually a radical change for most people to change their diet and eat differently. A lot of them have never done it before. I remember when I first did mine years ago, as a dietitian, it was a radical thing to do. I was just eating wheat every single day. So we'll talk about reintroducing foods and how important that is, because that's, to me, where the rubber hits the road is how you do that. Now, the literature shows that if you have a clinician hold someone's hand, you have a higher success rate. And this study looked at dietary education in groups or one-on-one. And they found a higher compliance rate if someone had access to a coach or a dietitian. You want to carefully screen pharmaceutical preparations, toothpaste, oral contraceptives for fillers, excipients, things like that. All vegetables are allowed. And I realize that there's different permutations of the elimination diet. We drilled down, and this is what we thought was a good foray for many people that were going to start doing this process. If someone has arthritis, they might want to think about eliminating the nightshades, which are potato, eggplant peppers, tomatoes, cayenne, and chili peppers. Solanidine and timanidine are in the nightshades. They can trigger things like scar pruritus. And a lot of my patients actually feel better when they get off the nightshades. All fruits are allowed. They can be fresh, canned in its own juice, no sugar, cooked or poached, frozen, diluted juices. And if you suspect candida, then you might want to say 1 or 2 pieces a day. Again, it's not a zero fruit diet, and this is not a low carbohydrate diet. The goal of this diet, again, is just a departure kind of from the South American diet. Grains, rice is okay. Now, this is for the population that's not eating a lot of rice normally. You want to look at your population, and if rice is a daily staple for them, then they will need to leave that alone. In the literature for elimination diets, it's important to walk away from foods that you have on a daily basis once or twice a day to get better. And people can develop sensitivities to foods that they're eating all the time. Dry cereals such as puffed rice is okay. Quinoa is a good substitute. Millet, buckwheat, amaranth, teff, tapioca. Poultry, fish, lamb, wild meats, beans and lentils. Some people might want to exclude those because of the lectins. Initially, I just have my patients eat those. Pine nuts, flax seeds, and coconut is fine.